Hey everyone, my name is Steven Allerhand. I'm here on the call with my colleague Ilya Ostrovsky and our former chief resident and current ultrasound fellow at Arizona, Jeremy Carter.
Hi, guys.
Hey guys.
So guys, I think I told you this, but during my fellowship, can't tell you how many times a resident would call me over to the bedside to tell me they had a patient with tamponade. I'd walk over there, I'd see a patient comfortable playing Sudoku with totally normal vitals, and I knew it wasn't tamponade. And yet, I didn't know how to explain that echocardiographically. So I did some reading. The upshot of that is that Jeremy and I published a narrative review in the American Journal of Emergency Medicine on echo for tamponade.
Hey guys, I really appreciate you including me. That knife doesn't hurt at all, okay?
Sorry, we'll move on. Anyway, just to get started, so Jeremy, why don't we play a game called Tamponade or No Tamponade?
Okay.
What do you think?
Looks like a pericardial effusion, and I see diastolic collapse of the RVOT, so I would say that's tamponade.
All right. What about now?
I guess an asymptomatic patient, no, probably not really.
Okay. How about now? And now? And
Maybe,
now?
maybe, and then at the bottom there, I would say definitely yes, tamponade.
Yeah, I think you get a sense of what I'm getting at here. I mean, ultimately, look, you can't make the diagnosis by clinical exam alone, right? Is anybody placing a needle in the chest if they hear muffled heart sounds? You also can't do it by echo alone either for the reasons that I told you. I mean, if the patient has time to call their spouse and primary doctor for advice about whether to consent to the procedure, well, maybe they don't have tamponade physiology. Ultimately, bedside echo should be performed when there is suspicion for tamponade based on the history and physical exam. And our brand of ultrasound that we do is at the point of care. So it ultimately determines whether or not we do that procedure or send them upstairs for the window or not do it at all.
I feel like the mountain needs probably toxic doses of lidocaine for this procedure.
Yeah, or none at all. Maybe none at all.
Damn right.
So I like to keep things simple. Plus, I know my audience; it's you two. So, really, just four things I want you to take away from this lecture. These are the four echocardiographic findings of pericardial tamponade. You have effusion, you have diastolic RV collapse, systolic RA collapse, and a dilated IVC with minimal respiratory variation. Let's start off with pericardial effusion. So normally, between the myocardium and the pericardial sac in the pericardial cavity, you have less than 50 cc of lubricating fluid. Once you get to about 15 to 35 cc, you can actually see the separation of the layers with very high sensitivity and accuracy using POCUS in both the medical and trauma settings. Once you have sufficient amount of volume, you might see the heart swinging like this. But the sensitivity for this is low. Do you guys know what this is on the EKG?
Pulsus paradoxus.
Electrical alternance. Close enough, right? You see the voltage kind of shifts. I know. This is why we kicked them out of our program. Anyway, moving on. So, guys, I believe in being systematic, right? I think for communication between ourselves and our consultants, and also for documentation, it's important to characterize our effusion. So the critical care community likes to use the diameter here between the myocardium and epicardium and diastole, but I think a better methodology works better for the ED environment. So it's trivial if you see it only in systole when the chamber is contracting and you see the pericardial fluid, once it contracts. It becomes small once you see the effusion throughout the entire cardiac cycle. It becomes moderate once it surrounds the entire heart, and anything beyond that is considered large. I mean, look, all that being said, a single cardiac view can misrepresent the volume of the effusion. So it's therefore important to acquire multiple different views of the heart for better characterization. So here are some examples. You see a trivial effusion. You can kind of only see it during systole. It becomes small once you see it throughout the cardiac cycle. You kind of see it a little bit here anteriorly. Not the best example. It becomes moderate once it surrounds the entire heart. Excuse me, I spoke wrong. Small is when you see it throughout the entire cycle. Moderate when you see it throughout the entire heart. And obviously here you have a very large pericardial effusion. But Jeremy, tell me, the size of the effusion, is that what determines tamponade?
I think that it's also related to the rate of accumulation.
Yeah, exactly right. So
Size doesn't matter.
size does not matter entirely. So mostly
Entirely.
it's related to the rate of rise of the effusion and the pericardial compliance. These are the two variables that determine the filling pressures within the pericardial space in relation to those within the pericardial chambers, the cardiac chambers. And I think this is well represented by a pressure volume curve. This is probably the most important slide in terms of describing the pathophysiology. So let's start here on the left. In the acute setting, the pericardial space is non-compliant. So even 50 cc of fluid can lead to hemodynamic compromise if that fluid has accumulated rapidly. Moving on to the right, over a longer period of time, the more compliant pericardium can stretch, such that even a very large effusion may not cause the hemodynamic compromise. That being said, of course, once you reach a certain threshold right here, even a small increase in fluid can lead to tamponade. So let's go over some potential pitfalls in looking at pericardial effusion. Ilya, you want to tell me what is going on here?
So I definitely see two hypoechoic things, right? And I think this is a really common mistake that we all make, or at least we've heard of, right? So you see that, I think the most important thing is to see that descending aorta right there, and then decide whether that hypoechoic, black stuff is anterior to the descending aorta, making it a pericardial effusion, or posterior to the descending aorta, making it a pleural effusion.
Nice. Jeremy, what's going on here?
This is something that's commonly confused for pericardial effusion. It's called a fat pad, and it's usually located here on our parasternal long axis in the atrioventricular groove. It also has kind of an echoechoic appearance instead of an anechoic appearance, kind of a stippled appearance, and then you'll see it move with the pericardium, and not really competing for space with the heart, but moving with the pericardium.
That was perfect. All right. So here is an effusion in each of the four main views. Rob Arnfeld and Brett Nelson, and thereby their fellows, like to say that one view is just a hypothesis. What here is that in one view, you might see a seemingly large effusion that suddenly does a large in another cardiac view. Alternatively, you might not see an effusion in your first acquired view before suddenly seeing it in all the others. It's also important to have a checklist for each view when evaluating whether an effusion is causing tamponade. Here I like to see whether there's RV diastolic collapse. And in these bottom two views, I look for collapse of the right-sided chambers. So let's move on to our second finding, diastolic RV collapse. So the RV has a thinner and more compliant wall with a lower pressure system than the LV. Its pressure is at its lowest in early diastole as it is filling up. So naturally, that's the point in the cardiac cycle at which an increase in intrapericardial pressure will cause the ventricle to bow inward. So whether the RV collapses during diastole is determined by this simple relationship. Whether pressure in the pericardial space exceeds pressure in the pericardial chamber. I know you guys, I know you don't want to hear any math, so let me simplify it down. The intrapericardial pressure, right, on the left side, will increase with increased pericardial fluid volume and an increase in pressure change in relation to the volume change. And this finding carries a very high sensitivity for tamponade, specificity. The sensitivity is only about 48 to 60%. And these diagnostic values are affected by changes in blood volume. For instance, the RV might collapse earlier if the filling pressure is lower at baseline, such as with hypovolemia. Same thing with pressure. If the RV filling pressures are elevated at baseline, it follows that not diastolic collapse will less likely occur. And that might be the case with acute or chronic cor pulmonale, pulmonary hypertension, or other etiologies of RV hypertrophy. So let's look at some images. Here in the parasternal long axis view, the heart is actually a little bit off axis. The aortic outflow tract is not completely well visualized. Nevertheless, as the mitral valve opens to indicate diastole, the RV outflow tract can be seen collapsing downward. Some people have likened this to a little man jumping on a trampoline. And the severity of tamponade is correlated with the duration of the chamber's collapse. That is, the period over diastole over which the intrapericardial pressure exceeds the RV filling pressure. So let me ask you guys this. Are you able to nail down the precise timing of the mitral valve opening and the RV free wall coming inward?
No, I think that's really hard.
Depends on how good you are, Steve. Depends how good you are.
Ilya's got eyes like a hawk.
Yeah, right, with my like huge thick ass glasses.
Especially with tachycardic patients, it can be really tough to get the timing down.
I agree. And I even edited the clip down to slow it down for you, because due to the distance of the mitral valve and the RVOT from one another, you just can't see it at the same time. But there's a remedy for that. It's called M mode, with its better temporal resolution. So Ilya, can you tell us, since you felt so strongly, can you tell us what's going on here?
Well, when I'm not wearing my glasses, I'm using M mode. So it's a great thing you could do. You click the M mode button on the machine, drops that little icicle through the screen, and what you're seeing is, whatever you're, measuring along that line, you're seeing that on the y-axis, and then along the x-axis, you're plotting that over time. And so you're really able to kind of see what is the RVOT free wall doing during diastole, because we know that when that mitral valve is open, that's when diastole is occurring. So we can just look up and see, hey, how's that free wall looking up there?
Exactly. So you see, why don't we correlate that with this one, Jeremy?
Yeah, so this one doesn't look like tamponade. If you follow that mitral valve up to where it's open at the top point there, and then just continue straight up the screen, you see that it doesn't look like the RV is collapsing right there.
Very nice. So less likely tamponade. So to get in some learning repetition, here is a parasternal long axis view where we see a small effusion with RVOT collapse. Here, there is less diastolic collapse of the RVOT. Looking now at the parasternal short axis at the mitral valve level, we do see RVOT collapse, and as a fish mouth of the mitral valve opens, and as a tricuspid valve opens, indicating diastole, the RV free wall collapses downward. And since these structures appear closer together, their timing is much easier to see here than in the parasternal long axis view. So why don't we contrast that with this clip in which there is no diastolic collapse, and maybe a little bit of RV hypertrophy here from baseline right-sided filling pressures. Now we have the apical forward chamber view. We have a nice clip of RV diastolic collapse. Contrast that with this clip here, in which there is no diastolic collapse from what is likely a chronic pericardial effusion. Moving on finally to the subxiphoid view, we can see that the RV barely expands at all due to compression from the increased intrapericardial pressure. Contrast that with this clip in which there is no diastolic collapse. And just like we said again, look how thick that RV is, probably some baseline RV hypertrophy. So now I want to show you a few interesting clips I actually came across on what we call Ultrasound Twitter, which is where all the cool kids hang out, and you guys should come in sometime. Actually, maybe not, only for cool kids. So why don't you tell me, what do you think is going on here? And I'll give you a little clue. Do you see this little reverberation artifact right here?
I'm going to give this one to Dr. Carter to handle. This looks like a tough one.
Huh. It does look at first like a like there's a pericardial effusion there, but it's something just doesn't look quite right because of that kind of artifact and the brightness of the pericardium or the line there.
Yeah, this is actually a pacemaker lead. So you see the reverberation artifact, kind of a cool, very cool little clip. And how about this one? I mean, here you do have tamponade, but as you can see, the RVOT isn't coming down at all. So this kind of goes against that sensitivity being high I talked about earlier. This is a loculated pericardial effusion that's constricting opening of the LV. Also a very cool clip. So now we talked about diastolic RV collapse. Let's move on to systolic RA collapse. So the right atrium is at its lowest pressure during systole, or to be technical, more precisely, in late diastole at the onset of atrial relaxation. During that period, it is thus most susceptible to collapse from increased intrapericardial pressure. This is the earliest sign of tamponade, and it has very high sensitivity. The specificity is much lower. I mean, the studies range from between 33 to 100%, and that increases when the duration of chamber collapse is greater than 1/3 of the cardiac cycle. Otherwise, the movement may simply be mistaken for normal atrial systole. And here's a nice little bonus pearl. The absence of chamber collapse has a 90% negative predictive value for tamponade.
Now, is this just chamber collapse referring to the RA, or is this all chambers?
No, that's my mistake. So that's both right-sided chambers.
Okay.
Just clarify that. Both right-sided chambers. So here in the apical 4-chamber view, we see systolic RA collapse. Matt and Mike from the Ultrasound podcast liken this to a little man punching up on the trampoline. We can also see systolic RA collapse in the subxiphoid view, like that.
That effusion looks kind of hyperechoic there. So is that maybe a hemorrhagic effusion?
Yeah, it is. I don't know, honestly. I'll have to ask Josh. It's kind of interesting that you don't actually see that down here. It's a good question. Finally, let's move on to the IVC that we all love and we all hate. So in tamponade, the IVC will be dilated with little respirophasic variation. So during normal respiration in the spontaneously breathing patient, negative intrathoracic pressure leads to increased venous return to the right atrium. In tamponade, there is compression of the right atrium by the increased intrapericardial pressure. As a result, the RA cannot accommodate the incoming preload, and thus there will be a hindrance of systemic venous return, and the IVC will remain dilated. The IVC, like the directly connected RA, carries a very high sensitivity for tamponade. Specificity is much lower, around 40%. As you know, a dilated IVC can be caused by CHF, severe TR, and a range of other etiologies. So the IVC is best seen in the subxiphoid view with the IVC and right atrium in long axis. So Jeremy, can you tell us where to measure this?
So you measure this typically, the IVC, just proximal to the confluence there with a hepatic vein, which you see coming down. And that's usually about 2 to 3 centimeters from the IVC RA junction.
Exactly. And I don't like using M mode because if you have your icicle, as Ilya calls it, not perfectly perpendicular, you might overestimate the diameter of the IVC.
It also can move with respiratory variation, right? So if you're measuring it in one spot, then the patient takes a breath, and then you'll measure it in a different spot.
Absolutely. So considering that we're only looking for the plethoric or collapsible extremes of the spectrum, an eyeball assessment is sufficient. I mean, the literature calls plethora to be a diameter greater than 2.1 centimeters with less than 50% variation with respiration. But again, evil eye of Sauron is sufficient for this indication.
But I think this is really important that we definitely make sure we do the IVC assessment, specifically in these, and it's up for debate how useful IVC is in certain instances. Again, really great at the extremes, but specifically for tamponade, to look at the IVC is so important, and then tell our cardiology colleagues again what we saw there as well.
Exactly. So Jeremy, what's going on here?
The IVC definitely is small and collapsible right there.
I agree. So we've now gone over the 4 core echocardiographic findings of tamponade. I'm going to add a bonus finding. It's a little bit tougher to understand, so Jeremy, feel free to zone out for a bit. Pulsus paradoxus.
I know I will.
Yeah, I assumed you would. Pulsus paradoxus reflects the exaggeration during tamponade of the normal respiratory variation in systolic blood pressure. So let's talk about it. So during inspiration, right, here's pulsus paradoxus. During inspiration, that is negative intrathoracic pressure, air is pulled into the lungs. There is a drop in pulmonary vascular resistance, and blood flow through the right side of the heart across the tricuspid valve increases. The 2 ventricles, and now the effusion itself, compete for space within the pericardial sac. The increased intrapericardial pressure from the effusion causes the RV and LV and diastolic pressures to equalize. As a result, with inspiration, the intraventricular septum indents further towards the LV versus how it would without an effusion, and an exaggeration of what we call ventricular interdependence. Less blood will thereby flow through the left side of the heart across the mitral valve, and it leads to a drop in LV stroke volume. This appears or manifests as an abnormally large decrease in systolic blood pressure greater than 20 millimeters of mercury that we know as pulsus paradoxus. So I told you how we have a decrease in systolic blood pressure. A surrogate for that is decreased blood flow through the left side of the heart. And a surrogate for that is decreased blood velocity through the mitral valve in the left side of the heart. Thereby, the mitral and tricuspid valve inflow velocities can be measured using pulse wave Doppler from the apical 4-chamber view, with the beam oriented parallel to the direction of blood flow and the gate placed just past the tips of the valve leaflets. The velocities should be measured at the first heartbeat after the change in respiratory phase, or in other words, sample the tallest E wave and compare it to the lowest. And here are some parameters that we can use that correspond to tamponade. Just be aware that there's a lot of variance in that. This will occur due to imprecise and varying alignments of the sample volumes of the beam and patient positioning. For tamponade itself, pretty cool finding. This finding has 82% sensitivity for tamponade. And when you have a pericardial effusion already, the positive likelihood ratio is 3.3. But be aware that that may also occur with marked dyspnea, COPD, or PE. And you might even have variation of inflow velocities up to 10%, even without tamponade. So in summary, here are the 4 core echocardiographic findings to understand and recognize in evaluating for pericardial tamponade. As mentioned before, you have pericardial effusion, diastolic RV collapse that is specific, systolic RA collapse that is early and sensitive, and the dilated IVC with minimal respiratory variation that is very sensitive. As before, this image summarizes the pathophysiology very nicely and is probably the most important slide. Here are the references. If you prefer the written version, feel free to check out our paper. And that's all we got for you today. Thank you very much for listening, and we hope that was helpful.
Thanks, Steve. Thanks, Jeremy.
Yeah, thanks, guys. That's good.